Good morning, ladies and gentlemen. It is my great pleasure to present during annual meeting of the International Society of Oncoplastic Endocrine Surgeons. Today, I would like to talk about posterior retroperitoneoscopic adrenalectomy. Actually, laparoscopic adrenalectomy has been introduced to surgical practice in 1992 by Eli Higashihara in Tokyo, Japan, and the same year Michel Guénier in USA. But technique of posterior retroperitoneoscopic adrenalectomy has been mastered by Marcin Barczyński, who in 1995 published his initial technique of dorsal retroperitoneoscopic adrenalectomy, and he put a lot of efforts to master the technique in the coming years. But even more than 25 years ago, he was able to identify that this surgical technique might become a major advancement in adrenal surgery. Actually, many endocrine surgeons utilize this posterior retroperitoneoscopic adrenalectomy for tumors smaller than 6 to 8 centimeters. Transperitoneal laparoscopic approach is reserved for larger tumors like 12 or even larger tumors. An open adrenalectomy is reserved for the minority of patients nowadays, like patients with the huge tumors and also suspicion of adrenocortical cancer. Laparoscopic approach from the lateral part of the abdomen may be challenging in obese patients, may also need for intraperitoneal adjacent organs dissections. Some adhesions, which can appear in 30% of patients after previous abdominal surgery, may be a challenge as well. And particularly small tumors on the left side in obese patients may be challenging to be dissected. So to overcome all those disadvantages, posterior retroperitoneoscopic adrenalectomy offers a direct access to the adrenal gland. It allows for bilateral adrenalectomy to be done in a patient without need for repositioning. So the major limitation is the space of retroperitoneum which needs to be created, and hence the tumor limit is around 7 to 8 centimeters, not more. In the beginning, it's of course challenging because of difficult anatomy, as the operative field in the operative is from the upside down perspective. So for the very beginning, it may be a challenge to operate. The indications are the same for this posterior retroperitoneoscopic technique, so most commonly glycocorticosteroidoma, aldosteronoma, pheochromocytoma, and also non-functioning adrenal tumors larger than 4 centimeters. There are several steps which are necessary to have this technique successful. First of all, patient positioning in prone position. The distance between the 12th rib, tip of the 12th ribs, and iliac crest should be at least 2 to 3 fingers to allow for placement of trocars and to have ergonomy of work in this retroperitoneal space. So the first trocar is made for the incision is made under the tip of the 12th rib, and then blunt dissection is done using the 10 millimeter scope. This is what we can see as we introduce the scope, and at the same time, high pressure of 20 to 25 millimeters of mercury is used to fill in this created space with rigid endoscope. As we have initial space created, we can continue with placement additional 2 trocars, one 10 millimeter port to the midline and one 5 millimeter port to the lateral part from the initial trocar placement. So as we create the retroperitoneal space, we identify the upper pole of the kidney, which serves as a very nice landmark. When the adrenal gland is located, it is always above the upper pole of the kidney. So we process with the dissection of the inferior margin of the adrenal gland and the superior part of the kidney. As this dissection process goes on, we identify on the right side vena cava, and we also dissect right adrenal vein. In the past, this vein had to be clipped and cut. Nowadays, it's not necessary. Energy-based device like ligature allows for safe division of this vessel without need for clipping. As this major vessel on the right side is clipped, we can continue mobilization of the adrenal gland with energy-based device from the lateral and also upper part. Even if we have a small tear in the peritoneum, it's not a problem usually. There's no need for converting such a patient because this retroperitoneum is nicely kept with the insufflation of 20 to 25 millimeters of mercury. As the adrenal gland is entirely removed from the surrounding tissues, dissected off, it is evacuated in endobag, and at the end, the final control of operative field, if there is any bleeding, is necessary. To make this process, we need to decrease the pressure to 8 millimeters of mercury to observe if there's no bleeding. Usually drain is not necessary to be placed in this area, and wounds are closed and dressings are done. We compared our initial experience in Krakow, more or less more than 10 years after introduction of this technique in Essen by Marcin Barczyński. So we compared our experience between 21st procedures done in Krakow, Poland, 10 years after invention of this technique. What was extremely important, that first we were observing different videos, watching different videos with the operations. Then the next step, we visited Marcin Barczyński in Essen to see a couple of operations over several days. And for our initial 3 cases, we invited Marcin Barczyński to join us as a surgeon to Krakow, Poland, to help as assistant during our first operations. And as a result, the mean operative time of our 50 procedures was significantly shorter than during the invention phase when these operations were done in Essen. So because the technique was mastered over the years and we were introduced to this major technique, so it is very important to keep in mind this process, observation video, observation live operations, and also using help of master surgeon during initial operations done in center. So what improvements were made over the years in the technique? So first of all, abandoning of the use of balloon dilatator, which was initially used to create the retroperitoneal space in favor of blunt dissection with a rigid endoscope and blunt tip dissector under visual control. Also important is an increase of capnoperitoneum pressure to more than 20, even 25 millimeters of mercury, which allows for easy retroperitoneal space creation without adverse hemodynamic effects. And also wide mobilization of the upper pole of the kidney as one of the first steps of the operation, which allows for direct access to the lower part of the adrenal gland. Another issue is introduction of generous resection of retroperitoneal fatty tissue around the adrenal gland in obese patients. Use of energy-based devices can be done both for dissection and for separation of all the vessels. In the past, other than main adrenal vein, nowadays ligature allows for safe separation also of the main adrenal vein. And certainly avoidance of routine drainage of the retroperitoneal space is possible in cases of almost bloodless operations performed with the use of ultrasonic energy-based device. In a multi-center study that evaluated surgical learning curve for posterior retroperitoneoscopic adrenalectomy in specialized endocrine centers, it turned out that between 24 and 42 procedures are required to fulfill the entire learning curve of this technique. In a randomized controlled trial that we published in 2014 with a 5-year follow-up, in this trial we had 65 patients enrolled, 33 underwent PRA and 32 laparoscopic approach. There were no significant differences between the indications and 2 groups, but major outcomes were different and beneficial for this posterior retroperitoneoscopic technique, so duration of surgery was shorter. Also, intraoperative blood loss, postoperative pain was diminished after this retroperitoneal technique in the first 48 hours after the operation. Also, prevalence of shoulder T-pain was shorter after this back procedure. Also, an additional analgesia request, prevalence of nausea but not vomiting, and also time to oral intake of clear liquids and solid diet, as well as the shorter lengths of hospital stay after this retroperitoneoscopic technique. On analysis of risk of duration of surgery of more than 90 minutes, obese patients, of course, were at risk of longer surgery, and also patients were approached with a transperitoneal laparoscopic approach had longer time of surgery at our hands. So this study demonstrated that both techniques were equally safe. However, there were many benefits of this removing the adrenal gland from the back. Another randomized study was published in Korea 2 years ago. It was a study in which more than 80% were involved in both arms, transperitoneal and posterior retroperitoneoscopic arm. There were no significant differences in the operative time in general. They were comparable, but patients who had pheochromocytoma were certainly at risk of longer operation, independent on the technique that was utilized. Also, there were no significant differences in hemodynamic instability during both types of the operations for pheochromocytoma. Also, in this Korean study, patient had similar postoperative pain on 2 days after the operation, and also time to water intake, time to solid diet intake, and length of hospital stay were not significantly different. So Korean colleagues just concluded that their study showed that both techniques had no significant differences in the operative outcome, including operative time, blood loss, postoperative pain, length of hospital stay, and complication rate, and both techniques can be performed safely for benign adrenal tumors, and either approach may be selected according to the surgeon's preference and experience. In a systematic review and meta-analysis that was published last year, there were 12 studies involved, 3 randomized and 9 non-randomized studies. It was clear that estimated blood loss was lower after posterior retroperitoneoscopic adrenalectomy. The same for time to oral intake, which was shorter after PRI method, and also length of hospital stay was shorter among patients who underwent posterior retroperitoneoscopic adrenalectomy. Another step in the development of this technique was invention by Marcin Barczyński's ZARA technique, which is a single-access retroperitoneoscopic adrenalectomy. In this technique, Visiport is used to make only one incision under the tip of the 12th rib. Retroperitoneum is created under direct visual control, and then the first trocar is removed. The 5mm trocar is inserted, and another 10mm trocar. To allow for ergonomy, 5mm scope is used, and through a single 10mm incision, 2 5mm ports are used to visualize the operative field and also make dissection with a single energy-based device. Obviously, it is more challenging technique, but for a master surgeon, it is possible. And as shown by Martin Watts, it was not very difficult to make this dissection using only one instrument in the operative field, energy-based device. Obviously, the tumor is removed through the single incision in endobag, and cosmetic outcome is very nice. As shown as a comparative study, some case-controlled patients, this ZARA technique was beneficial in terms of lower pain medication that was necessary after such an operation, and more patients didn't require any analgesia after such an operation than after conventional 3-port technique. So authors concluded that this technique of single-access retroperitoneoscopic adrenalectomy is feasible, safe procedure in well-selected patients with adrenal diseases, and it had minimal perioperative morbidity and pain, and may supersede notes in adrenal surgery. Also, in obese patients, this single-port retroperitoneoscopic adrenalectomy turned out to be technically feasible, and if performed by experienced hands, it allowed for offering perioperative outcomes comparable with those of conventional multiple approach, but with a superior cosmetic outcome. And one more important issue, that robot-assisted technique may be also utilized for the single-port access for posterior retroperitoneoscopic adrenalectomy, as it was shown 10 years in Korea. This technique is feasible for well-selected patients. So, to sum up, there are a few important findings. In my personal opinion, this posterior retroperitoneoscopic adrenalectomy has several advantages, so not only less time in the operating room, but also a little bit less blood loss during surgery, significantly less scarring, which is so important for patients, reducing the risk of surgical access. Site herniation is a very very big importance, but also less postoperative pain, faster recovery, and return to normal activity, and also shorter hospital stay. What was very important, this posterior retroperitoneoscopic technique was found to be very safe when compared with the traditional transabdominal laparoscopic adrenalectomy, and also this PRI technique was helpful, particularly for tumors present in both adrenal glands, which can be observed in 10% of patients, and also in patients who had extensive abdominal surgery in history. So thank you very much for your attention, and I would like to invite you to join us for this virtual surgical congress in August 30 through September 3 this year. It is a conference including International Association of Endocrine Surgeons. So please join us. Thank you very much for your attention once again. Bye-bye.